Today we'll be discussing about Ludwig's angina. What is Ludwig's angina? Ludwig's angina is a life-threatening infection that presents as cellulitis of the soft tissues of the floor of the mouth and the neck. It is a cellulitis of the suprahyoid neck area. The suprahyoid neck has two spaces. Coming to a quick revision of the anatomy and the spaces, the suprahyoid neck has two spaces. Suprahyoid neck means the neck portion above the hyoid bone. So it has two spaces, sublingual space and submandibular space. The mylohyoid muscle divides the sublingual and submandibular space. The space below the mylohyoid is submandibular space. The space above the mylohyoid muscle is the sublingual space. What are the boundaries of the submandibular space? The submandibular space is bounded anterolaterally by the mandible, superiorly by the mylohyoid muscle, medially by the anterior belly of digastric, and inferiorly by the hyoid bone. This is where the deep fascia attaches. This submandibular space is enclosed by a superficial layer of deep fascia, except along the posterior margin of the mylohyoid muscle, where the submandibular space continues with the or communicates with the sublingual space. What are the contents of the submandibular space? The superficial part of the submandibular salivary gland. Then you have the facial vein and facial artery, and the hypoglossal nerve traverses or they course through the submandibular space. What are the boundaries of the sublingual space? We know that the inferior boundary is mylohyoid. Infrolaterally by the mylohyoid muscle, then anteriorly by the mandible. It is like this, no? So anteriorly by the mandible, medially by the midline genioglossus and geniohyoid muscle. Superiorly, the sublingual space is under the tongue. So sublingual. Superiorly, you have the mucosa of the tongue and also the floor of the mouth. The right and the left sublingual space communicate anteriorly under the frenulum of the tongue. So this is the anatomy. So Ludwig's angina involves these two spaces. It causes cellulitis of these two spaces and it can progress into abscess. Angina. Angina in Latin means to choke. So this means that it can become life-threatening, causing less respiratory distress and airway compromise. Because with this space, the pus can spread via the muscular planes and it can involve the epiglottis, larynx, parapharyngeal space, retropharyngeal space, etc. True Ludwig's angina is described as the infection of the submandibular space, but Ludwig's angina can also involve the submandibular, sublingual, submental space. What is the etiology? The infection most commonly spreads from the dental caries or dental infection. Most particularly, the infection occurs from the second and third molars. The periapical abscesses occurring on these teeth can spread into the sublingual and submandibular space, causing Ludwig's angina. The roots of the premolars are above the attachment of the mylohyoid muscle. So initially, it spreads into the sublingual space. And the roots of the molars are below the attachment of the mylohyoid muscle. So initially it spreads in the submandibular space. Whether it is spreading into submandibular or sublingual space doesn't matter much because over course of time it can involve all the spaces. Other etiology apart from dental infections are any trauma to the floor of the mouth, like any oral piercings, any laceration, any mandibular fractures, any traumatic orotracheal intubations, then any submandibular cylidernitis, any infected thyroglossal cyst, and also the infection can spread from the peritonsillar space or peritonsillar abscess or parapharyngeal abscess can involve the submandibular space. There are certain systemic risk factors that have been identified for patients who develop Ludwig's angina, like diabetes mellitus, uncontrolled diabetes mellitus, patients undergoing hemodialysis, malnutrition, alcohol overuse, patients with other cause of immunosuppression like human immunodeficiency virus, acute immunodeficiency syndrome, or patients in therapeutic immunosuppression like organ transplant recipients. These patients are prone to develop a Ludwig's angina from a dental infection, and also these patients are more prone to develop complications. What is the microbiology? It is a polymicrobial infection. It can be aerobes and anaerobes causing the infection. The most common is Staphylococcus, Streptococcus, Streptococcus bacteroides, all can be involved. Streptococcus anginosus is involved in more rapid progression. And also in diabetes and immunocompromised patients, there can be Klebsiella are also isolated from the culture. There is also risk of infection with the MRSA in immunocompromised patients. What is the history and physical examination? The patient presents with pain, so difficulty in opening the mouth. The patient can give a history of dental pain, a prior dental pain or a dental procedure or dental extraction, etc. History can be there. and patient comes with odynophagia, pain during swallowing, dysphagia, difficulty in swallowing. If it is a progressed state, patient can have symptoms of respiratory distress. Patient can have noisy breathing, stridor, change in voice, drooling of saliva. Patient will be coming and sitting, leaning forward with open mouth because they have respiratory distress. What are the clinical examination findings? You can see that there is swelling around the neck and there is edema of it is mainly cellulitis. Before abscess formation, it will be cellulitis. So there is edema and swelling of the floor of the mouth, edema and swelling of the tongue. The tongue will be elevated, pushed upwards and backwards. There will be trismus. There will be induration of the submental neck and edema of the neck. And also the neck of the patient is known as bull neck. Another condition where we say bull neck is in diphtheria. Then also the voice change will be there. So it will be hot potato voice. Patient may not be able to speak also because if there is respiratory distress and drooling of saliva and all, patient won't be able to speak also. So in that cases, we have to stabilize the airway immediately. Coming to diagnosis, the diagnosis is mainly clinical diagnosis. So you see a patient with swelling of the floor of the mouth and difficulty in swallowing, odynophagia, dysphagia, and your examination is showing induration and all that. Your clinical tentative diagnosis is Ludwigs angina. And if patient is in stridor or patient is in respiratory distress, and if you feel that the airway is compromised, you have to stabilize the airway initially before going in for further investigation. You can do a CT or ultrasound of the neck if the patient is stable. The CT will show soft tissue stranding, muscle edema, subcutaneous fat attenuation, etc. You can take a swab and also aspirate some pus for culture and sensitivity and other microbiological testing. Also, a general blood investigation can be done to assess the counts. Blood culture can be done if the patient is immunocompromised and you have to for suspecting septicemia and all that. All that supportive investigations have to be done. Coming to treatment. The main treatment is airway management. The airway has to be stabilized. Recent guidelines say that you can go for an awake, flexible, fiber optic nasotracheal intubation. If that is not possible, if we have to go for a tracheostomy only, do tracheostomy and stabilize the airway. Blind nasotracheal intubation or blind intubation has to be avoided in patients with Ludwigs angina because it can cause a rupture of the abscess, bleeding, exacerbation of the edema and laryngospasm. We can start the patient on broad spectrum IV antibiotics. We have to give antibiotics against the aerobes, anaerobes and also the oral microflora. Whatever is there in the oral cavity, we have to give antibiotic therapy to cover all this. You can use ampicillin, sulbactam, clindamycin. In resistant cases, you have to go for piperacillin, tazobactam, cefepime. In MRSA, you have to add vancomycin or linezolid, etc. If you have done a pus culture and sensitivity, and once after 24 or 48 hours, if you are having the reports, you can change the antibiotics accordingly. Intravenous corticosteroids and nebulized epinephrine can be used to reduce the edema, the oropharyngeal airway. Steroids, we have to be very careful when prescribing steroids to patients with uncontrolled diabetes mellitus and all that. The sugars can spike and the blood sugars has to be controlled simultaneously. Usually we use dexamethasone. Also nebulization of adrenaline can be given so that the edema is reduced and the airway can be stabilized more easily. Coming to surgical drainage. Surgical decompression of the suprahiatal neck is important for stabilizing the airway and clearing the abscess formation. If there is abscess, it has to be drained so that the pressure on the airway is reduced and the tongue can come back to the normal position. If the abscess is limited only to the sublingual space, you can do an intraoral incision and drainage. At the floor of the mouth, you can open and drain, suction the pus out. But if the entire submandibular space is involved, we have to do a external incision and drainage. The incision is usually made parallel and 2 finger breadths inferior to the mandibular angle. Sometimes if the abscess is localized, you will have to do multiple incisions are also required. Displace the submandibular gland, divide the mylohyoid muscle and decompress the affected facial tissues and remove all the pus. If there is no discrete abscess and airway is secure, we can actually wait by giving IV antibiotics. And if the patient is not responding to the antibiotic therapy, you can go for an incision and drainage if abscess develops. But the imaging is revealing an abscess and also you can feel the fluctuation and on aspiration you're getting pus and also the patient's airway is compromised. The removal of the pus or decompression is absolutely necessary to secure the airway. We will have to go for incision and drainage immediately. And also sometimes the extraction of the infected tooth may be necessary so that the infection is contained. What is the prognosis? It is a good prognosis if diagnosed early and treated early. The mortality has reduced to 8% with early diagnosis and proper management. Before the advent of antibiotics, it used to be 50% mortality because the spreading of infection will be very fast, and also there will be associated airway compromise. What are the complications? The complication is airway compromise. The infection can spread not hematologically or lymphatically. It spreads along the facial planes, including the parapharyngeal space, retropharyngeal space, mediastinum, causing mediastinitis. Summarizing, Ludwig's angina is cellulitis of the soft tissues of the floor of the mouth. Sublingual and submandibular compartments can be involved. It is mostly caused by dental infection, and immunocompromised patients are more susceptible. Patient present with trismus, odonophagia, dysphagia, sometimes in respiratory distress, stridor, hot potato voice, bull neck. Our initial priority is stabilization of the airway. Then we have to give IV broad spectrum antibiotics. Nebulized adrenaline and corticosteroid injections can be used to reduce the edema. Surgical drainage if abscess is there.